Hi, this is Professor Garvey, and I'm going to record this brief lecture for you. This is a lecture that I actually gave last year, and we decided this year that these topics really don't rise to the level of a full lecture, so I have greatly condensed the slides, and we're just going to go through these topics in a much more superficial way. So hopefully you find this information helpful. If you have questions, please let me know. So we're going to be talking about endocrine tumors and also diseases that affect males. We'll be talking about multiple endocrine neoplasia syndromes, gastroenteropancreatic neuroendocrine tumors, try to say that 3 times fast, and then carcinoid tumors. So first, multiple endocrine neoplasia syndromes, MEN. So these are rare inherited disorders where the endocrine glands develop benign or malignant tumors, or the glands just grow excessively and do abnormal secretion of hormones. These are the MEN tumors. There's 4 discrete categories. MEN1, really you're thinking about tumors involving parathyroid, pancreatic, and pituitary. You can also have adrenal, thyroid, carcinoid tumors, lipomas, and angiofibromas with this, but the first 3 are the biggest part of that syndrome. MEN2 are medullary thyroid cancer, pheochromocytomas, and Hirschsprung disease, which is a GI disease you're going to be learning about in January. MEN3 is also medullary thyroid cancers and pheochromocytomas. They also develop Marfan-like body types where they have longer limbs than normal. And they develop mucosal neuromas, so tumors in the mucosa. MEN4 involves primarily parathyroid gland, looks a lot like MEN1, but they also can develop tumors in the ovary, testicle, kidney, and other areas. So MEN1, typically, they develop hyperparathyroidism. They have the enteropancreatic tumors and pituitary adenomas. And you can see there that the hypoparathyroidism is the most common presenting symptoms. MEN2 and 3 are really very closely tied to medullary thyroid cancer. Almost all patients with those genetic syndromes have that particular cancer, and often they have bilateral pheochromocytoma as well. MEN4 looks again a lot like MEN1, except for they have the additional tendency to some other tumors that MEN1 doesn't. They're distinct because they're different genetic defects. So MEN are diagnosed by genetic testing, and treatment just depends on which type of tumors they have present. Often, if it's possible, they're going to want to resect that tumor. Because MEN2 and 3 even have such a high rate of medullary thyroid cancer, kids often that are known to have that will have prophylactic thyroidectomy to try to prevent. Okay. So now moving on to gastroenteropancreatic neuroendocrine tumors, GEP-NETs, and carcinoid tumors. So GEP-NETs are tumors that arise in stomach, intestines, and pancreas. They release amines or hormones, but half of them may not actually secrete them or secrete them in levels that don't produce symptoms. They're becoming More common, mostly because we're accidentally discovering them more as people are getting scans. And up to 25% of these are also associated with a form of a genetic disorder. Carcinoid tumors arise from intestine or lung tissue and secrete serotonin, and they're prone to metastasize. So there are many types of GEP tumors. Pancreatic tumors secrete glucagon and insulin, somatostatin or gastrin, depending on the type of cells that are present. Insulinomas secrete insulin. They typically present with low blood sugars because there's too much insulin on board. They're more often benign. They often are just a solitary insulin secreting tumor unless it's part of an MEN1 syndrome, and then they might have multiple tumors secreting insulin. Gastrinomas secrete excessive gastrin. They tend to present with symptoms that are developing because that gastric acid is causing problems. So abdominal pain, heartburn, GI bleeds, about half of these are malignant. They can be found in the duodenum, the pancreas, or lymph nodes. In particular, this group tend to have a long delay from when they first have symptoms to when they're actually diagnosed. These symptoms get chalked up to a lot of other things. Glucagonomas present typically with weight loss, diarrhea, nausea, peptic ulcer disease. Up to 35% of them will have developed diabetes mellitus. These are often malignant, and they can co-secrete other hormones. Somatostatinomas and VIPomas tend to present with diabetes, cholelithiasis, steatorrhea. They're secreting excessive somatostatin and VI vasoactive peptide. These are really rare. Non-functional PMETs. So these are the ones that tend to produce no significant hormones, and because they're not having symptoms from hormone release, they usually grow very large before they're detected. They usually get symptomatic when they are either large enough to obstruct or press on other structures, or when they metastasize and cause problems. CCK-omas produce cholecystokinin. They tend to present when they metastasize to the liver, or when people develop diarrhea, peptic ulcer disease, or weight loss. And then carcinoid tumors. These can arise from multiple areas: small bowel, colon, esophagus, lung. The thing to know about this group is that they can present with carcinoid syndrome, which is a syndrome where they have facial flushing, skin flushing. They get red and they're dry, they're not sweaty. They can have wheezing, they can develop diarrhea and facial telangiectasias and heart murmurs. The diagnosis of each of these is based on what type of hormone they're secreting for the most part. So you're looking for elevated levels of those hormones. And they all can have an elevated chromogranin A as a tumor marker. You also might do imaging to look for the tumors by CT or MRI or ultrasound. Treatment for all of them: surgical removal. Now we're going to move on to endocrine diseases that affect males in particular: hypogonadism and gynecomastia. So gynecomastia is palpable breast tissue in males. This can be completely normal, especially as adolescent males go through puberty. They tend to develop this, but then it will resolve spontaneously. It's more noticeable in males who are tall or who are overweight. Also, males who use any kind of steroids or androgens can develop this. And a genetic syndrome, Klinefelter syndrome, can have this as a main presenting symptom. It can also be a side effect of other drugs. Symptoms and signs. So you have to distinguish whether this is true glandular tissue that is enlarging the breast area or if it's just some fatty tissue. The way to do this is you compare subareolar tissue to the surrounding tissue. Fatty tissue is typically kind of diffuse and non-tender, whereas if it's true glandular enlargement, it tends to be asymmetric, lumpy, and the area beneath the areola may be tender. If a male has what appears to be true gynecomastia, you also want to examine the testes for size and masses, because this can be part of a larger hormonal syndrome. And you need to inspect the penis for hypospadias, which is when the, let me change this so you can see it here, when the urethral opening is not centrally located, but is on the underside of the penis. The red flags for concerning of breast cancer in males: if the tissue is asymmetrical from one side to the other, the area that feels abnormal is not beneath the areola, unusually firm, or any nipple abnormalities like nipple retraction, bleeding, or discharge. Diagnosis: we're looking for abnormal hormonal levels. Serum prolactin can be elevated if there's a prolactin secreting tumor. Elevated beta HCG, which is typically test for pregnancy, tends to implicate that there is a testicular neoplasm. Looking for abnormal testosterone levels, luteinizing hormone, and estradiol. Imaging tests that can be helpful: bilateral mammogram, a chest x-ray looking for metastases, or doing an ultrasound with needle biopsy. Treatment: if they are going through puberty, it's probably going to resolve spontaneously. Just watch it. If we think it's drug-induced, we stop the offending drug. Otherwise, we really only treat if this is a very troubling or persistent issue. Medication treatments tend to have a lot of side effects, but we can use raloxifene or tamoxifen and aromatase inhibitors. They can be somewhat effective, but we don't use those in adolescent boys ever. Occasionally, surgical correction is an option. Tends not to have great results. And if we have a male who is being treated for prostate cancer, they are sometimes treated with radiation to the breast tissue to prevent gynecomastia, as that is a potential effect that happens with prostate cancer. Hypogonadism: this is a disorder caused by deficient testosterone. So in primary hypogonadism, the issue is that the testes is not producing enough testosterone. This could be secondary to mumps or chemo or radiation. The testes just hasn't ascended. They haven't entered puberty. It could be part of that genetic Klinefelter syndrome. It could be results of tumors. Secondary is low testosterone due to dysfunction of other endocrine structures, hypothalamus and pituitary. Symptoms and signs are primarily symptoms of testosterone deficiency, low libido, erectile dysfunction, depression, fatigue, not able to sustain strenuous activity. They could develop gynecomastia, not having normal facial or body hair, poor muscle mass, small testicular volume are all potential symptoms. You're looking to diagnose it by checking testosterone levels. Sometimes an LH or FSH can be helpful as well. If the cause isn't clear, you might do other labs looking for underlying problems. Treatment is testosterone replacement. It's not for everyone. It can worsen BPH. It's contraindicated if they have prostate cancer. It can worsen some other conditions like sleep apnea. Sometimes they can be treated with gonadotropins, and if we think that the main issue is obesity, then recommendation would be weight loss. That is the end of this mini lecture. Please let me know if you have questions or if something is unclear.